Okay, good afternoon, everyone. Good morning to those of you on the West Coast, and thanks for joining us today for our COVID-19 update, laboratory and pathology billing in the time of COVID. Everyone is automatically muted, so no need to worry about muting your line. We do have a chat and Q&A function available today. If we have time, we will address the Q&A questions live during the webinar. If we don't have the time or resources, we will be making notes of all of those questions, and we'll be following up with you after the conclusion of the webinar. A recording of the webinar and the slides will also be made available to all attendees. So for our agenda today, this is the second in a series of free webinars we're doing on COVID-19 billing and coding. And so we wanted to offer an update on some of the things we covered in early April. First off, we'll be looking at where we stand now and offering an update on the COVID curve revenue projections that we've been compiling for our clients. We're going to explore the HHS provider relief funds and how to calculate your second round of payments if you have not received that yet. We'll be looking at the Medicare Advance payments, understanding a little bit better about how and when recoupments will take place since those deadlines are approaching for folks who took those funds. We'll be doing another update on the CMS billing and coding guidelines with a particular focus on the changes to serology testing. And we'll be looking at some of the CMS reporting relief efforts, including changes to the merit-based incentive payment system and PAMA reporting, before closing out with a summary on some of the current trends. Our speakers today are Mick Raich, Vachette CEO and founder, Dustin Sunthimer, our Vice President of Sales and Marketing, Ann Lambrix, our Vice President of Client Services, and myself, Alex Mitchell, who I head up quality reporting oversight for our clients. And with that, I'll turn things over to Mick.
Thank you, Alex. Boy, it's an interesting time. I'd like to thank all the people who are on this call and all our current clients that get called in. I've had a pleasure to talk to a lot of our clients in the last couple of weeks and kind of touch base. It's been interesting to see how things are going and how they're responding. What we see now is at this point in time, everyone's starting to rebound. You know, some of our groups are going slower than others. Some of the labs barely had a dip. Other labs had a 70% loss in volume, and they're starting to rebound real well. One of the things we're seeing that's kind of holding things up is a lot of COVID testing before elective procedures. I know there's places around the nation where people are still struggling to get those tests done in a timely manner so the elective procedures can start up. So we're starting to see the upward swing here, which is a good thing. All right, it's time to come out of this. I think it's time to move on and try to figure out how to work in a whole new world the way we're going. We're starting to see some billing issues too. We have questions about pooled specimens. We've had a couple questions about that come in. We're looking at revenue models for COVID-19 testing and different ways that labs can do that, or even different ways that employers can do that. And then we're actually had to try to pivot and look at some different business strategies for some of our groups and some of the labs out there. Right now is a really interesting time. There's a lot of different stuff being thrown up to discuss, a lot of different business models being drawn up right now, and hopefully we'll have some good ideas for people going forward. Understand this is how it's going to be, and there's going to be opportunities here. Some labs are going to do very well, some groups are going to do very well, and some aren't going to pivot so strongly. Alex, just look at the next slide. If we take a look at this, this is the projection we did for all our clients. We sat down and at the beginning of this, and we revised it even after an update came in April, to kind of look at, well, where do we think things will go for our groups? What will it look like? We wanted to know if you're going to take a 50 or 70% pay cut, what does that look like? How do you build your cash flow model going forward? How do you control your expenses? You know, that's something we were real cognizant of with a lot of our clients. We reached out and made their expense for Vachette considerably less because we knew they were hurting and we were hurting also. And That's part of a business partnership is. So if you look at the dark blue line here, you can see where our initial projection dropped down and then popped back up come July. And yet, if you look at the actual revised line of gross charges, you can see it slowed down in April a little bit, and dropped straight down in May, and we think it's going to rebound real good in June. In fact, we know some people that are going to be their June charges are going to be at 110 or 120%. So it'll be interesting to see how this fills out going forward. The one thing you want you to look at here is May, how all the numbers almost all come together. That was probably the closest realization of what our projections and what actuality actually happened and where we're at. Once May revenues finished up, I'd like to see where that finishes up and how it collects there. And then June and July going forward, hopefully we'll see that spike in charges in July and June, and then you'll see a little spike in payments come end of July and August, and we'll be back on where we want to be by September and October. So let's go ahead and look at the next slide here, Alex. I'm going to turn this over to Ann. She's got some great comments here. I'm going to stay on the line because there's some things I might want to inject also. So Ann, why don't you talk about what's going on with the provider relief funds?
Sure. Thanks again, everyone. I second all the agreement of how much we appreciate our clients and those that are on the call today. As you know, we've seen multiple communications from Health and Human Services regarding their provider relief programs. The first distribution took place around April 10th. And you're, I'm sure, familiar with the second round of distribution, which you have to apply for. That is applicable through the Provider Relief Portal. If you are interested in applying for the additional funds that may be available to you, you must attest, and it's by June 3rd, so we're looking at next week, on that original funding that took place, again, on or around April 10th. In order to determine whether or not you have potential for additional revenues through the provider relief, Health and Human Services has updated their FAQs around May 14th, indicating some calculation based on approximately 2% of your 2018, and they say your patient revenue, which is actually all your revenue coming from insurance, patient, et cetera. Taking 2% of that 2018, you should come pretty close to what you should receive from the general distribution funds in both. So you would have that first round. And so, for example, let's say you did the calculation and you received you should receive $60,000 and you received $40,000 the first round on April 10th, you should be eligible for an additional $20,000 from HHS. And that additional $20,000 you will need to apply for. And that is, again, what is available. And Alex, if you want to do the next slide, and kind of just talk about the additional, the expected distribution is that 2% of 2018. I know we've had several calls regarding how to, if groups should apply for the additional funds, and again, if you take that calculation of 2% of your 2018 revenue, and then look at what you received on or around April 10th and see if there's additional funds that would be available to you, then yes, you should apply. Applying is relatively simple. Again, it is through the Provider Relief Fund portal through the CARES Act, and you would click on for providers, and then there is a link to go for the, it says to submit your financial data. Go ahead, Mick, if you had any additional information you wanted to add.
I wanted to ask you, what percentage of the clients our clients do you think are going to get the second wave here, are going to actually apply for it?
It really depends. It depends on the type of client that you are. I would say with at least 30% of our clients would be eligible for additional funds.
Good. And you say there's an attestation they have to do by, I think it's next Wednesday for the first round of funds, correct?
Well, my understanding, Mick, is that this all needs to be completed by June 3rd. So meaning not only do you attest to the first round, which, as I keep mentioning, that was your first payment that you received on or around April 10th that was deposited into your account with the HHS stimulus line. That needs to be attested by June 3rd. And then you also have to, if you want the second round, provide financial data. So you have to submit an application through the provider relief by June 3rd.
And what happens if you don't do this correctly? Is there a carrot or a stick here?
So again, if you're attesting to the initial distribution,
right,
that you have to attest. If you do not attest, they will assume you've accepted the money and you agree to the terms and conditions.
Okay, because I think we're going to get a lot of calls.
That money.
Yeah. We're going to get a lot of calls come end of June. People saying, "Well, I got the money and I kind of spent it. What do I do now?" I mean, so.
Well, you're right, and if you have those questions, please don't hesitate to contact us. There are some, per the terms and conditions, you have to document how you are spending this money. There's some way of tracking it. Yep. Right. So that does not change from the first or the second round. You are still accepting the same terms and conditions. There's just additional funding that's available. And again, you must apply for. The first round you didn't have to apply for it. It was just given to you, and you accepted it or you returned it. The second round, you have to apply for any additional funds, but to see if you are eligible for additional funds, you might want to just do the calculation of 2018 revenue, 2% of that, to determine, based on what you got in April, if there's any additional monies that you may be due. Now, keep in mind as well, all applications will be considered, but there is no guarantee that they will be paid. So there is a deadline of June 3rd. So if you have not submitted and you think that you're going to submit, I recommend highly to go ahead and complete that. The application is simple. There is a very nice how-to. If you go onto that portal, it says, please access our user guide. The user guide, I believe, is a very user-friendly guide on how to apply for that second round. And it shows you the little bit of documentation you will need to submit to HHS for consideration. The initial response from HHS on these applications, they indicated that they would respond within 10 days. I will say that for some of our clients, it is taking longer than 10 days, but we are starting to see that those applications are being reviewed and distributed with the additional funds. The next is the Medicare Advance. That was the first, big round of additional funding that was made available through the CARES Act. However, the advance is simply an advance. It is a prepayment to you if you applied and received this, and it must be paid back. Different from provider relief, where again, that would be as if you accepted the terms and conditions, you do not have to pay that back. The Medicare Advance does have to be paid back. CMS has stopped accepting applications as of April 26th. So if you've received a Medicare Advance, what we want to make sure that you keep in mind is that this does have to be paid back, and it will, CMS will start recouping this advance 120 days from the date that you received the funds. So this is something where you and your biller will need to track and make sure that you're keeping an eye on when these recoupments will start taking place. And then they will take place between 120 days and 210 days of the receipt of the advance. So there's a 90-day period there between 110 and 210 days where Medicare will be recouping that advance that they gave you. And so you'll see that Medicare revenue drop in those months for a period of 3 months while you're repaying that advance. From my understanding, once that 210 days is up, you will receive a demand letter if you have not paid that balance in full, and then you will start accruing interest of 10%. Now, I did see that there has been some pushback from providers and some various industry leaders on trying to waive that 10% or reduce it, or get some a longer period of time to pay it back. But I have not seen that has been successful as of yet.
No, Ann, this is an interesting thing. I think it's going to provide some interesting challenges for billers and for cash flow models when this money starts coming out, because I think a lot of people are going to see their cash flow go up. They got their Medicare payments, the advance, and then come, I'm going to guess August, probably a lot of people will be getting these recoupments back on their Medicare, and they'll watch their Medicare dollar go down and their cash flow go back down.
Right.
It'd be an interesting time to do modeling. Yeah, go ahead.
Right, absolutely, and that's where you go back to the COVID curve, and the COVID curve is a great visual to apply to how revenue will dip and rebound. But if you have taken the Medicare Advance, that is something that, again, you should see August, September, October, hopefully rebound and come back to normal averages. But if you took that advance, most likely that rebound will not take place, not in your bank account, because you've been able to reduce your decrease in the earlier months. So that is where, yes, as far as a model, you'll have to take that Medicare Advance recoupment into play as well.
And what percentage of the clients do you think didn't take the Medicare Advance?
Again, this was when the Medicare Advance came out. I would say that many jumped on board because this was before we got that free distribution. So all that was available really was the PPP and then this Medicare Advance. So I would say a large portion of clients did move forward with the Medicare Advance. And again, a lot of billers that we work with are able to track this and help assisting while we monitor the recoupment. I wanted to quick answer a question before we move on. The second payment is based off of the collected revenue for 2018, not the billed.
All right, thank you, Ann.
Okay.
And we'll pass things over to Dustin now.
Hi, everybody. Good afternoon. This is Dustin with Vachette Pathology. Just want to thank everybody that has joined us this afternoon, and my best wishes that everybody is safe and still healthy. A lot of what I'm going to be, or some of what I'm going to be going over today, is going to be a little bit redundant. It's some older information mixed with some new, and it directly relates to billing for the various types of coronavirus testing. Now, as most of you know, the CDC came out early with their real-time PCR diagnostic test for identifying the coronavirus, and to properly code that, the U001 code, which has been established, was used and still not as frequently being used anymore, but it's still there. It is still valid and good on any testing done after February 14th. Through our experience, speaking with our clients, speaking with our colleagues across the industry, the 3591 has been very consistent reimbursement with Medicare and some of the commercial payers as well. Next slide, Alex. Now, in conjunction with the U001 code that came out, the U002 code, so that was any type of LDT that used the amplified probe technique to identify the coronavirus and subsequent COVID-19 disease. The U002 was laid out with a $51.33 reimbursement. This too, much more popular after you had gone down through the EUA process. we have been seeing pretty consistent reimbursement with this test code as well. However, when we get to the end, I will talk to a couple of variations in that. Now, for anybody that's interested, if you could just go back real quick, Alex. Sorry about that. The actual list of the FDA EUAs are available at that website right there. You can look at that when the slides are emailed out afterwards. Okay, next. More recently, CMS and the FDA, or I should say CMS, came out with an advanced methodologies and accelerated payments for any type of amplified probe that is making use of high throughput technologies. This is both for the U003 code, the U004 code, and the differences between the two are just that, just a second. You can see the two differences there. Again, these are being reimbursed at $100 a piece. Again, very consistent reimbursements through across the country with our different clients and our colleagues. A couple of caveats though. The biggest one, even though that there is high throughput technology for the serology testing, neither the 003 or the U004 should be applied for that particular type of testing. And below you can see a couple of examples for high throughput analyzers that those two codes apply to. Next, Alex. So a unique aspect of the 876, the CPT code 87635. Again, this is essentially the U003 code, but not performed on a high throughput analyzer. We have not seen this code throughout with our clients and colleagues. I will say has been one of the lesser used codes. The reimbursement is still strong at $51.31. And again, with our laboratories that are using this code, strong payments across the board. Next, please. Now, this is the serology testing has been hands down the most frequently asked about technology with my clients, with colleagues, with just people calling in and asking about this. Before we get started on the different codes and the reimbursements, I do want to tell you that last Friday, the FDA delisted 28 serology tests. The vast majority of these tests were manufactured overseas. And there were various reasons that they were delisted. There were a couple of voluntary withdrawals, but mostly that they didn't follow protocol when pursuing the EUA through the FDA. And as many of you know, if you did do LDTs in your specific laboratory, that you went to your state regulation or state regulators, anything manufactured outside the U.S. obviously is going to have to go through the Federal Bureau. The 12 FDA approved or authorized tests can be found at that website and will be sent out after this webinar. 86328. These are the test strips. The finger prick or the poke. Add a little blood and watch for the bars. 86768 is the multi-step method, and again we're seeing a lot of this testing coming in through our clients. I will say that I do not believe that we have seen any type of reimbursement information on this yet, but please feel free to give us a call after you've seen or have questions about that. We'll be happy to look into that for you. Next slide, please. So to kind of wrap things up on my end a little bit, let me tell you about, so some of the caveats we were telling you about. Laboratories, many of you on the telephone right now are doing RT-PCR testing, and you're doing serology testing. Some of the things that we have been seeing with our clients is that while in state, if you're doing specimens in state for your patients and or clients, and billing within your state, we're seeing very consistent CMS reimbursements. But I will tell you that if you are receiving specimens from across state lines, we are seeing some variation in payment. It doesn't fluctuate that much, but we are seeing some variations in that reimbursement and those reimbursement rates. The strongest reimbursements right now are coming through Medicare and state Medicaid programs. And we will say that we're starting to see denials. The clients with whom we're working right now, in this next month, we will be getting into the denial codes and be able to talk about that on our next webinar. And one of the other services, and my final point will be that, as Mick alluded to, one of the biggest problems with getting all of your laboratories and your groups back up to speed is being able to test patients going in for surgery, test them for coronavirus before going to surgery. Now, if they are, a type and cross is generally good for 3 days, and if you can't get a COVID-19 result back in that time, that's going to cause an issue in being able to open up more surgeries and subsequent pathology work and or laboratory work. Vachette pathology, since the beginning of this, since the beginning of the COVID crisis, we have been maintaining an active list of laboratories that can either accept your specimens or that are willing to send them to you. If you've got any questions about that, or if you do have excess capacity, please reach out to us. We'd like to add you to our list or make a referral for you. Thank you very much for your time, and I will leave this, the rest of this to Mick and Alex.
Thank you, Dustin. I'm just going to take over for a real quick slide here on some of the regulatory reporting relief that has come via the various waivers that have been issued throughout the public health emergency. If you were with us on our last webinar, a lot of this will be a rehash, but I think it is worth restating. So for starters, anyone who was participating in the quality payment program for 2019 was likely aware that you had the opportunity late in the game to opt out altogether. The reporting deadline was originally set for March 30th. That was pushed out till April 30th, and then participants had the chance to file a hardship exception application that would allow them to receive a neutral adjustment altogether in 2021. Now we're currently in the midst of the 2020 reporting year, and no changes have been announced so far. So proceed as usual with your MIPS reporting. That's not to say that later this year or early next that there won't be another opt-out option because of the hardships caused by the COVID crisis. But as for now, you should continue as if you will be submitting your QPP scoring in the spring of next year as normal. Now, in terms of PAMA reporting, that was also delayed another year to the first quarter of 2022. And that's after the Lab Act last year initially pushed it back a year to 2021. So we're really on a 2-year delay with this now. The good news is that the CLFS rates for 2021 were frozen, and there will be no 15% reduction as initially scheduled for those clinical lab tests. But keep in mind that when the reporting comes around in the first quarter of 2022, you'll still be reporting your private payer data that you collected between January and June of 2019. So it'll be interesting to see how that plays out and how it affects rates in the future. And as for the Medicare physician fee schedule, we're currently anticipating some large proposed cuts for pathology and radiology services, an aggregate of 8% due to proposed E&M changes. There have been no announcements so far whether or not those changes will be put on hold, and that would be obviously a pretty substantial cut to institute after everyone has been through this year. But the proposal for the fee schedule will come out in July. We'll be monitoring any changes there, before the final rule is published later in the fall. And with that, I'll pass it back to Mick.
Thanks, Alex. You know, the news on these fee schedules is interesting. I can't imagine a world where they'll come out and cut pathology 8% starting next year after the drastic changes we've had now. Something that we didn't note there that's going to affect cash flow going forward is how does your state Medicaid program deal with the loss of revenue? That's something that we're going to see, and we're going to have to start building into our models, because as state revenue dollars go away, they have to cut revenue and they have to cut services to the Medicaid side. And we anticipate many states coming across the board with a Medicaid decrease to providers. It could be 5 or 10 or 20% in some places, because if your state doesn't open up for a long time, there's no revenue going in, and they have to cut revenue one way or another. They can only cut so much in, you know, in staffing and that type of thing, and providers will be a juicy little tidbit on the chopping block. So keep an eye out for that, and we will on our end. Some of the trends we see going forward that are still what ifs. For example, will the state come out, or a national law come out saying that everybody in a company with over 300 to 500 people have to be tested? Okay, I've talked to a couple different people around, and I actually know some people who are connected to the government, and this is something that's actually been being bandied around right now. We're not sure how it plays out. Could COVID testing be mandated by your employer? And who does that testing? That's a whole nother angle. And then once that testing is done, how do you perform contact tracing? There's, you know, pros and cons in each of that. Imagine if you go out and you work with a company that has 1,000 employees and they open up a mini lab to do testing there. Well, now that company that has 1,000 employees making doorknobs now has to have a HIPAA policy to handle all the testing results and such. One of the models we're talking with some people about now is that concept of a mini lab, and who's going to run a mini lab inside these businesses, and how does it look? How does the compensation look like that? Dustin alluded to it earlier. We're already seeing denials. You know, you're not going to be able to get a COVID test once a month and have that compensated by payers. We see this with a lot of skilled nursing facilities. They want to test all their patients, and they want to test their staff every 2 weeks. Well, that's great, and it's probably a very healthy play, but at what cost? I mean, someone's going to have to pay for the cost of that test and to get done. And I'm pretty sure that, you know, if we look at the current insurance trends, you know, preventative medicine isn't high on their list. They're not going to come out and say they're going to pay you $14 per test, but this is done. There'll probably be an ABN for the Medicare type and Medicare Advance plans, and then the commercial payers. Who knows how we're going to have to deal with that going forward. Let's hit the next slide, please, Alex. Laboratory trends. We saw laboratories volumes drop to 40% in about the middle of May, and it was really, really hard. Now, some labs were able to make some of that up with COVID testing, and they were able to pick that volume back up and handle it and keep their cash flow strong. Others were not. You have to look at these pivot strategies. You know, who can you work with? Who can you do testing for? The big question going forward is, you know, just how many of these tests will have to be done, and what will they look like going forward? What platform will they use? How will they be compensated? I know that I think it's the $100 rate on some of the testing is only good till January 1st of next year. So if you spend $400,000 for a machine and reagents and get it up and running, but your business model only has 9 months or 8 months, well, that's a tough time to make an ROI. So that has to be addressed. Also, pathology groups, looking there. Will this force more consolidation in pathology groups as things tighten down? Will they be able to recover come July and August with all the testing? My thought is by August or by the middle of July for sure, most hospitals and surgery centers will be up and be real strong again on their testing. They'll be able to provide these testing before the patients go to the elective surgery. Like Dustin quoted again, the concept of, you know, if you have to wait too long for your initial test, your COVID test to come back, then all your pre-op testing has to be redone. I don't think that'll happen. I think we'll find a way to handle that from a medical side. I'm not sure how we handle it from a financial side. So the other question we're looking at is There's a lot of groups in the last 3 years and 5 years, a lot of big pathology groups were rolled up into health systems, and health systems bought all these practices. Well, this is a very interesting time for them because their ROI on those practices is going to be terrible. It's my theory that I think, especially as we move forward, and depending on the election cycle, we'll probably see a lot of those practices that were purchased pushed back out into the fee-for-service model. It just might be not be feasible to have a pathologist or a radiologist on as a salaried employee anymore. If you are a pathology group, and this is something we noted in our last webinar, is let's build some goodwill. You know, if you can go to your health system and say, hey, we're going to take a pay cut on our Part A for the next couple months to help you over the hump, that's going to pay off really good in the long run. And that's what you got to look at this. This isn't a short-term game. This is a long-term play. Next slide, please, Alex. Now, here's where it's going to get sticky. Here's where we're going to get very busy. In fact, we are picking up clients at an amazing rate right now because people are starting to look at billing, and I feel this fall it's going to be even more interesting. How does turning off the bill cycle for 6 and 8 weeks and turning it back on look going forward? How are you going to be able to handle all that, and how is your biller going to be able to handle that? We see some very unique trends with billers. A lot of them laid off 1 or 2/3 of their employees, and they did just enough work to open mail and get some claims out the door. Well, who worked during those 8-week period of time? Who worked all the denials? Who handled the appeals that had to be done? I think a lot of billing companies are going to struggle not only to catch up and keep things going, but they might even struggle. And I talked to one earlier today who's struggling to hire somebody at this time. Due to the current unemployment rules, people are making much more on unemployment than they would actually working for these companies. And that's going to trickle on down in 2 or 3 months to your bottom line. So billing companies are going to struggle to handle this change. We're going to see them lurch back on and get going again. And we're going to have to be on top of that because we are going to find unique things. For example, we already found one billing company that was trying to build their billing costs for the advanced Medicare payment and for the HHS payment, which we caught them on that and had to pull that back. Insurance companies, same thing. Somebody at the other end of that line has to work those appeals once they go to the insurance company. And again, if India shut down for 21 days, there's 21-day backlog there. All those insurance companies have big cubicle farms there. Who's going to look at that? I see our June and July denial numbers being through the roof. We're going to see, like I said here, check your date of service versus your date of billing lag time. We're going to see charges that didn't get in time. We're going to see timely filing issues in June and July for cases that were in April and May that never got filed out in time. Remember, if you did a case in April and it sat there until the 1st of June, well, you got a 30-day filing limit. Guess what? You did all that work, you accepted the liability, and your billing never got done. It never even got billed. Tough time. So, moving forward, you know, this will make some consolidations in the billing industry. I see that happening already. This will lead to some consolidations in the lab industry, like as we've seen in the last 5 years. We know the big three have been building per roll-ups, so we see that continue to happen. The question you got to ask yourself is, what bold move are you going to make? How are you going to be aggressive here? You know, Vachette's been very lucky. We're led by just an incredibly group of aggressive individuals here. You know, right out on the tip of the spear, trying to take care of our clients and go the right way. And they all have great ideas, as you can see in these webinars. So as you go forward and you have questions and you're concerned, you know, don't be afraid to reach out to us. Don't be afraid to reach out to your friends. There's going to be different business models in the next 6 months, and some people are going to win and some people, unfortunately, aren't going to win. So, Alex, I think that's the last slide, isn't it? Yes, it is. I'd like to thank everybody for taking time. Alex, you want to go through the Q&A?
I think Ann is looking at that. Ann, anything that we can address right now, or are those better for follow-up?
A couple. I think that there'll be more for follow-ups. As far as the happening with patients who hurry to receive RNA tests, heard all tests will be covered without cost share, and the lab that did the test send it to lab X, and the patient's insurance had lab Y in network. I'm going to attempt to answer this, but I think it would be best to follow up, Steve, with your questions. You had a couple here. From my understanding, many of these payers, whether you're in or out of network, they are indicating that they'll pay without any cost share to the patient. So, and it doesn't matter of your in or out of network status. However, I'd be happy to look at maybe an example. And then the same as your question regarding the effect of cost sharing versus self-funded insurance plans. Again, it's going to depend on the particular plan. The objective here for a lot of these payers, it's a PR issue. COVID testing, you know, really if the patient goes in with severe COVID and they're inpatient for several months, they don't want, you know, a news blast that, you know, Humana or whoever, you know, billed the patient received a bill for, you know, thousands of dollars. So many of the big payers, included self-funding, have stepped up, indicating that these tests and the patient's inpatient coverage would be covered at 100%. Now, whether or not that is in actuality what's happening, that's a different story. So we can look at some of that.
Yeah, I think, let me jump in here for a second, Ann.
Yep,
I think one of the things that you will need to address is the number of times a COVID positive patient was balance billed. Because according to many of the guidelines, you're not supposed to do that. But as we all know, in the billing world, the worst thing you can do is tell them not to bill something. And we're going to see COVID positive patients balance billed. We're going to see people diagnosed as COVID retroactively where a balance bill already went out. And the OIG already came out last week and said they're going to step up their review of compliance on this. So this will be something we're going to have to take a really good look at. And I think most cases will just be an error. I think it won't be a fraudulent act, but I think we're going to have to pay close attention to that.
Yeah, and that brings a good point, Mick, as far as one of the things we're working on with our clients and the billers that we work with our clients is making sure that there's some sort of process in place to identify patients with COVID diagnosis, so that those billers are able to carve out and make sure that there's some sort of policy as far as billing those patients, whether it's in a charity adjustment or if they're submitting, if the patient is truly self-pay, if they're submitting those claims through the COVID uninsured portal. But again, those questions have come up several weeks ago, and we've worked on with multiple billers, ensuring that there's policies in place to identify and make sure that our clients are compliant with that balanced billing and not billing COVID patients for those tests.
Yeah, if I remember correctly, we asked all our billers to provide the protocol for that. Mm-hmm. And correct. I think we have 23 different billers, and there were a couple of them that said, we don't have that yet.
Right,
so,
right, yeah. We've I think, been successful in working through that with most of them, and just making sure that there's at least something in place, that there's that our clients are acting in good faith to comply with those terms and conditions. So, you know, again, that's something that if you don't work with Vachette, that's something that you do need to follow up with your biller to make sure that there's something in place. I think those are the only questions that I really feel comfortable answering. I know that there's a couple here that will follow up with you afterwards as far as your specific questions. There is about 15 minutes left, so I was going to say if you have any more, if you could put those in that Q&A. We'll give you a couple minutes here. Actually, I do see one here. Can you give the link to the COVID uninsured portal? I sure can. If you look into, it's the hhs.gov/provider-relief. That site, it's the CARES Act Provider Relief Fund, and it has all kinds of information on the provider relief, but what you're going to do is you're going to click on the segment that says for providers. And under that, there's the link to sign your attestation for that first provider relief fund that was given to you on or around April 10th. Then there is the second part of the general distribution portal where you can submit the financial data, which we spoke about at the beginning of our webinar today, where you can apply for that additional round. And then underneath that general distribution, submit financial data, there is the COVID-19 uninsured program portal, and you're going to click on that request reimbursement. And it walks you through how to set up that portal in order to submit claims and get paid. And you get paid for those uninsured COVID patients. Your reimbursement is 100% of Medicare. So again, this is a nice way that HHS is providing some relief to treating patients that have no insurance. So you'll get 100% of Medicare on those. The question of, can you add modifier 26 for CPT codes for COVID tests? At this point, I'm going to say, to the best of my knowledge, yes. We're talking about PCCP here. Keep in mind with PCCP, that is for the oversight of the laboratory. We wouldn't bill Medicare. Your governmental programs, you wouldn't bill that. However, for your managed products that pay PCCP, my understanding is yes, you could bill for that. However, I don't know how these commercial payers are going to respond to that. So the big issue here, if you do bill it, you need to make sure that you have something in place that you're not going to end up billing the patient. And so when we bill PCCP, a lot of times it's because we're out of network, and so we're able to do that balance billing. If you've accepted the terms and conditions, there's some limitations there. So that, again, is something that you're going to need to make sure that you have something in place with your biller, that it doesn't set you up for compliance risks.
Yeah, I agree. That's how I think that's a perfect way to approach that.
It really, unfortunately, with the managed plans, I will say with billing COVID, as Dustin alluded to, we're still seeing a lot of managed care where I'm still unsure of how they're going to pay. And so they're still getting their fee schedules loaded and determining how they're going to respond to this testing. But again, Medicare, Medicaid, we're seeing good reimbursement that way.
Well, thank you, Ann, for tackling those questions here at the end. And thank you, Mick and Dustin, as well, for the great insight you provided. I think that's where we're going to put a lid on things for today. But if you have additional questions, feel free to reach out to Mick's email address there on the screen. My email address, Alex Mitchell, is also available in your registration details. Feel free to forward those questions to me as well, and I will get them sent to the appropriate party, and we'll work to get you a response as quickly as we can. Thanks again, folks, and have a good day.